Hey, this is Ellen Encisco, research resident at Cincinnati Children's Hospital.
And Gerardo, the other research resident at Cincinnati Children's Hospital. Ellen, what are we doing?
We're going back through another installment of our article reviews from the Journal of Pediatric Surgery. So this is the October edition. We talked to a few authors again, and this time Dr. Paul Tam chose these articles for us to review.
I'm Paul Tam, Chair Professor of Pediatric Surgery at the University of Hong Kong, also the Regional Editor for Journal of Pediatric Surgery.
All of the articles that we talk about, we're going to give you a link below. So you can scroll down under the media player, click on the link. You can open up any of these, read along with us while you're listening, whether it's in the Stay Current Pediatric Surgery app or Apple Podcasts, Spotify, SoundCloud, Stitcher.
Okay, so first we have an article out of Texas Children's Hospital. It's called What Happens After the Hospital, an analysis of longitudinal care needs in children treated for child physical abuse.
So we were lucky enough to sit down with the author. She is a general surgery resident.
My name is Brittany Johnson, and I'm a fourth year categorical general surgery resident at the University of Mississippi Medical Center. And I did 2 years of dedicated clinical research at Texas Children's Hospital.
And she summarized this very eloquently.
There are a lot of studies that talk about, identifying patients in the ER, kind of documenting the injury pattern. But we were really wondering, especially with the children that have more serious injuries, what happens to them when they go home? We have a database within our hospital that tracks all of our trauma patients. So that's what we used and went through and pulled out the non-accidental traumas. Then we kind of looked at each patient, looked at their hospital course, what were their injuries, what consults did they have? And then we looked at their discharge instructions, like what follow-up was recommended, and then came back and followed them for a year to see how many of those visits that were recommended they actually made.
There was a pretty surprising finding in the results here. It surprised us and even surprised Brittany when she talked about it.
I do think the rates themselves were actually quite high to where the patients aren't following up as recommended, but the rates are not low. So I think my interpretation of it is that that's actually an opportunity, that these families are trying to make these appointments.
This article, the results really highlighted the need for multidisciplinary care in trauma patients in general and patients coming with after physical abuse, and the potential need for a medical home, as Brittany pointed out.
We might congratulate ourselves for having done a good job in perhaps saving the kid, in identifying the problem, but perhaps not aware that we have a responsibility for the long-term health. And we have to be advocates for the children.
Something that we can help them with. If it's developing a medical home, we talked about that in the paper, to have all of the visits done at one time. You can see a lot of the other systems in pediatrics, they do that. When you think of the kids that have complex medical conditions, they will make all of those appointments on one day. Why can't we do that in pediatric surgery for these patients? If they need to see multiple services, we can decrease the burden on the families and make sure that all of us are available on one day.
Yeah, I think that could be, with a follow-up article, could be it's a unique idea. I think it could be very helpful. It's hard at a given hospital to change the whole infrastructure for that, but I think that we're moving to multidisciplinary care, and this is one example of that. And the fact that, we're seeing 85% follow-up is surprising to me and encouraging.
So I think the next step would be looking specifically at the patients that did have lower follow-up and talking to those families. Then we can figure out and better understand what their reasons were so that we could attack them. I think the other thing is looking at, we mentioned briefly looking at accidental trauma as a comparison to this study so that we can say, is the follow-up really any different? Do the non-accidental traumas have a lower rate of follow-up compared to the accidental trauma? Is this something that is common to all of our patients? So I think those would be the two next steps.
The next one is called Surgical Necrotizing Enterocolitis, Association Between Surgical Indication, Timing, and Outcomes. And this article is out of the UK.
Yeah, Southampton. We got to talk to the senior author, Dr. Nigel Hall.
Thanks for inviting me to this podcast. My name is Nigel Hall. I'm a pediatric surgeon at Southampton Children's Hospital, which is on the south coast of the United Kingdom, and I'm associate professor here at the University of Southampton.
So he described the general premise of this article.
So this was a secondary analysis of a prospectively collected observational study that took place in all 27 pediatric surgery centres in the UK. So it's a whole population-based study, which I think is one of its strengths. And it was through this organisation called BAPS-CAS that was led by collaborator Professor Marian Knight, who really is the brains behind this organisation. And the data set comprised data from a year's worth of babies who had surgery for NEC in the UK. What we wanted to look at as the primary outcomes were death or parenteral nutrition requirement at 28 days after surgery. What we looked at was the reason why surgeons said they had decided to do the operation on these babies. And we also looked at the time period that elapsed between the baby presenting with a diagnosis of NEC and actually having their surgery.
And he told us, that he really wasn't surprised by these results, and that, finding that babies with necrotizing enterocolitis who fail medical management and end up going to the operating room end up doing worse than the patients who went to the operating room sooner because of perforation or suspicion for necrotic bowel.
I think what this was, that one of the first opportunities we'd had was to really document what we thought, if you like, was our underlying hypothesis, was that there did seem to be a relationship between the indication for surgery, so the reason why babies had surgery, and the time it took to get them to have surgery, and also the outcome at the end of the day. So overall, there were about 130 babies with NEC in this population, and about half of those had a bowel perforation. And then of the other half of babies, what we found was that about a third of them were really, really poorly. And the surgeon decided at the time that they were just really sick, and they proceeded fairly quickly to have an operation as well. Then there was the 2/3 of the babies, if you like, who didn't have a perforation, and they eventually got an operation. So their indication for surgery was what we called failed medical treatment. And there were two things about that group of babies. One is that they had the longest time from presentation to actually getting their operation. And also, in that group of babies, the outcomes were worse.
Now, the next step of these results, I kind of thought, and Todd kind of thought, could this maybe lead us to some sort of treatment algorithm, some sort of protocol?
It's about being able to identify the babies who need surgery early enough, and then also understand how surgeons make decisions about surgery.
This article points out the problem of gestalt in necrotizing enterocolitis. It's really easy when they have free air. When they don't, we're all different, and we don't have a defined protocol that's been built yet. And that's kind of what this article is sort of showing, is that when you don't have a definitive protocol, then you're going to be hedging and hemming and hawing every day about, do I go to the operating room?
It is obvious that we currently do not have the objective clinical markers, whether they are the clinical features or novel biomarkers, to help us make an earlier decision to operate.
Hopefully this has raised this part of the way we treat babies with NEC in people's minds as something that we could consider doing something about. But it's certainly going to be, I think, quite a lot of hard work to really change practice, but something that I really think is worth pursuing.
I think this is a study to keep poking us in the side to say, let's figure out how to use either a machine learning algorithm or some more machine-directed way of analyzing the data where we can see what constellation of data points tells you when the best chance of there being a surgical problem is.
And who knows, with AI, social media, and all this digital knowledge, I can't help but feel that some of these should be introduced into our algorithm in managing patients, rather than just the surgeon's clinical decision.
So then the next one is out of Nationwide Children's Hospital, and it's called 1 Year Impact of a Bowel Management Program in Treating Fecal Incontinence in Patients with Anorectal Malformations. And for this one, we talked to the first author, Dr. Wood.
Hi, my name's Richard Wood. I'm the Chief of Colorectal and Pelvic Reconstructive Surgery at Nationwide Children's in Columbus, and it's great to be here.
And he shared with us the outpatient bowel management program at Nationwide.
Yeah, so we started working here in Columbus in 2014 and established a bowel management program, but it was really in 2015 that we started recording the outcomes in a standardized way, because up until now, there really hasn't been the use of standardized definitions and patient-reported outcomes and experience measures within this field. And so we really wanted to do that in order to try and get a better understanding of the patient's experience of bowel management, because after all, it's a quality of life tool. And so we set up this cohort with all these standardized things in order to try and get an objective study of this patient population.
It was an important paper because prior studies have looked more at short-term outcomes after bowel management programs, and they decided to look at the long-term outcomes and see if the good results are sustainable.
We didn't want to measure it at 1 week because bowel management outcomes at 1 week really don't mean all that much, in that it's an artificial environment. You've removed people out of the environment. And so we chose to do our measure at 1 year because we wanted to be able to show that the changes that we had made were sustained and were sustained within their normal environment. But what we were able to show in the study was that if you look at the kids who were clean, their quality of life significantly improved. And if you look at the kids that are not clean, their quality of life did not improve at all.
Even after a year, there's still 30% of patients that went through this program that were still struggling with fecal incontinence. And so then, this paper also points to more research as far as addressing that group of patients.
It's very sobering to realize that although you throw all these resources at these patients, you have a cohort of 30% that you have not improved their quality of life and that they're still having accidents. And we all know that kids are mean, so kids having accidents at school is a real problem. I think what I wanted to do with the study was lay down a baseline for where do we go and which are the patients that we now need to drill into further. So now I kind of know 70% of the kids are going to do great. And what I really need to do is focus the attention on the other 30%.
Another thing to point out is that, not everybody that listens to this podcast is going to have access to a bowel management program. And this is kind of what Todd thought about that.
Honestly, a lot of people see the value of this, don't have the volume or the resources to build a formal program. And it's very reasonable to send these kids to a nearby bowel management program.
I think this is something that is very practical and can be used by all surgeons, this sort of message.
Good article. A lot of really important people put this together, so it's worth your time to read.
Yes. And the last one is also about patients with anorectal malformations. So this one is out of Italy, Rome, Italy. It's called Predictive Value of Spine Bone Anomalies for Spinal Cord Abnormalities in Patients with Anorectal Malformations. And we had the opportunity to talk to one of the neurosurgeons.
Hi, I am Giacomo Esposito. I am a neurosurgeon and I work in Bambino Gesù Children's Hospital in Rome.
And we also want to very much thank Bambino Gesù Children's Hospital in Rome, Italy, for working with us to coordinate the chance to talk to Dr. Esposito.
So in this study, it was a retrospective review of patients with anorectal malformations, and they were looking at the patients who, did or did not have spinal cord abnormalities, and they were trying to see how they correlated with imaging findings of sacral or vertebral anomalies.
The idea of this article was born from a clinical, practical observation of this patient. Our study is a retrospective study, and we analyzed 350 patients in a period between 1999 and 2019. I think that is one of the largest series.
And they wanted to see how much they correlated, which they found that they did correlate quite well, that patients with a sacral or vertebral anomaly were likely to have a spinal cord abnormality.
I think that the main results of our article is to have demonstrate the close relation between spinal cord and the spinal bone.
But they found that even though they correlated, there were still plenty of patients who did not have sacral vertebral anomalies, still had spinal cord abnormalities. And so they feel that MRI is still necessary to search for that spinal cord abnormality. After we actually spoke to a couple of pediatric colorectal surgeons that we know, and typically in the practice here or around us is to get an ultrasound shortly after birth, and that typically is sufficient to look for a spinal cord abnormality. And it sounds like in where Dr. Esposito is coming from, they have found MRI to be necessary to really look for those abnormalities.
There's variability in the use of ultrasound for figuring out if a patient has a tethered cord. It looks like radiographs are not a good substitute. And so we're still back to ultrasound versus MRI, and that still is not the same everywhere.
Yeah. I don't know where in the world you are listening to our podcast, but go ahead and leave a comment below, whether you're in the Stay Current Pediatric Surgery app or Spotify or Apple Podcasts. Leave a comment and let us know, what is your practice to find spinal cord abnormalities in these children with anorectal malformations?
This center's review provides us with sufficient knowledge that to convince anyone who is not doing regular or routine assessment of the spinal cord and the spine and sacrum itself, that they should be more serious with imaging.
Dr. Esposito also pointed out in our discussion and in the article the need for multidisciplinary care in these patients.
Our study is interesting because behind there is a multidisciplinary team. I work together general surgeon, neonatal surgeon, and urologist, and we create a multidisciplinary team and multidisciplinary workflow to the management of patients with anorectal malformation.
And I think that's a theme from all of these articles, is how many different physicians and healthcare providers are involved in the care of these complex patients.
Whether it is the pediatric trauma patient who necessitates follow-up, or the bowel management patient who needs to see the surgeon, the nurse practitioner, maybe he sees GI, maybe he sees someone else, or it's, in the NICU and you have a patient with necrotizing enterocolitis. It really, it takes a village for a lot of these, and it probably should, because, I think it only benefits the patient to bring in other minds.
So I think that's a good summary statement about the multidisciplinary care in all these articles. We'll keep doing more of these podcasts. We'll have one coming out from the November issue.
Yeah, keep your eyes peeled, ears peeled. Or if there's an article that we didn't highlight that you really want us to talk about, then find us on social media, subscribe to our YouTube channel, download the Stay Current Pediatric Surgery app. It's in the Apple App Store, it's in the Google Play Store. But until then, I'm Rod Gerardo.
I'm Ellen Encisco. And remember,
knowledge
should be free.
There we go.